Hello, everyone. My name is Dr. Luxey Sirisegaram, and I'm a geriatrician and assistant professor at the University of Toronto. Thanks to remarkable advancements in antiretroviral therapy, people living with HIV are living longer than ever before. But with that progress comes new challenges, particularly as they begin to experience multimorbidity, polypharmacy, cognitive change, and social isolation. These individuals are at the intersection of two specialities, HIV medicine and geriatric medicine. Yet there are few systems designed to bridge them. Despite this growing population, we know little about how older adults living with HIV perceive their healthcare needs and how well our systems are actually meeting them. That's what prompted this study. Our goal was to explore the lived experiences and perspectives of older adults living with HIV in Ontario, to identify the service gaps, barriers to care, highlight opportunities for more inclusive and coordinated models of healthcare delivery. We conducted community-based qualitative study in Ontario, Canada. There were 26 adults aged 50 years and older, reflecting a range of ages, gender identities, and ethno-racial backgrounds. They participated in either 14 one-on-one semi-structured interviews or 2 focus groups of 12 participants. They explored the participants' understanding of geriatric care, experiences within the healthcare system, and recommendations for improvement. All data were audio recorded and transcribed verbatim, analyzed thematically using the qualitative analysis guide of Leuven framework. So essentially, what we found were 4 central themes that emerged from the analysis. One was confusion and uncertainty. Many participants were unclear about what geriatric care actually involves and how to access it. Someone were said that they were not old enough despite clear age-related needs. This confusion extended to healthcare providers who often didn't know where to refer these patients. Stigma and ageism were the second theme, where they described feeling judged or defined by their HIV status, as well as avoiding care altogether due to stigma or dismissive experiences. Ageism and HIV-related stigma are often reinforced in one another, deepening the mistrust in healthcare system. The third one was social supports, where many relied on chosen family, peers, and HIV community organizations for emotional and practical support. They could not, however, replace formal coordinated medical care. And lastly, participants called for better provider education on aging while living with HIV, more culturally safe environments, and interdisciplinary models that integrated geriatric medicine, HIV care, and mental health. They also emphasized the importance of virtual and mobile outreach to reach those who face barriers to access. In summary, older adults living with HIV face systemic barriers to appropriate geriatric care, shaped by stigma, ageism, and lack of provider preparedness. The solution lies in developing inclusive, integrated models of care that bring together geriatrics and the HIV expertise that we have. Thank you.